Welcome, everyone, to the IPA webinar entitled Psychosis, Does Psychoanalysis Have a Chance? My name is Elizabeth Danzy, and I'll be moderating our session today. I'll say a few words about this topic. The webinar will focus on examining the potential and limitations of psychoanalysis in the treatment of severe mental disorders, especially psychosis. Psychoanalytic theories related to psychosis will be explored in depth, including the understanding of its underlying mechanisms and the interpretation of symptoms from a contemporary psychoanalytic perspective. The seminar will address specific technical experiences and adaptations of the psychoanalytic approach to working effectively with psychotic patients, highlighting success stories and challenges. Our guests today, our speakers today, are Alfredo Ortiz Fragola and Franco de Masi. Before I introduce them and say a few words about the format for the seminar, I will say a few words about myself. I'm a professor at the University of Texas at Austin, where my scholarly work focuses on the intersection of psychoanalysis and architecture, and most recently on the psychoanalytic dyad and how it might inform the teaching and learning endeavor. I'm a member of the Dallas Psychoanalytic Center in Dallas, Texas, and I'm very happy to be moderating this wonderful session today. The structure of the webinar will go like this. We'll have a presentation by Franco de Masi, a second presentation by Alfredo Ortiz Fragola, and then a discussion for about 20 minutes, and then we'll have a question and answer session. Those questions and answers will come, the questions will come from you all, and there'll be time. I will deliver those questions to the speakers and they will answer them. Please submit your questions from the question and answer section on the bottom of the Zoom bar. All the questions are anonymous. Again, they will receive the questions from me and we'll answer them that way. There are automatic subtitles in English that are available. Press the button in the bottom toolbar that says CC to enable them. The webinar is being recorded and will be uploaded to the IPA webpage and YouTube. You will be sent a link to the recording in the days following the webinar. Participants can only interact through the question and answer. Chat and microphone functions are not available in the webinar format. You must also connect with your name and surname. Okay, I would like to introduce our first speaker, Franco de Masi. He is a Training and Supervising Analyst of the Italian Psychoanalytical Society and former president of Centro Milanese Psicoanalisi and secretary of the Training Milanese Institute. He is a medical doctor and a psychiatrist who worked for 20 years in psychiatric hospitals. He has written many articles and 3 books on the origin of psychosis and its treatment. The first, Vulnerability to Psychosis, a psychoanalytic study of the nature and therapy of psychotic state. A Psychoanalytic Approach to Treating Psychosis, Genesis, Psychopathology and Case Study, and the most recent book, Beyond the Dynamic Unconscious, which will be published in 2025. The title of Dr. de Masi's paper is Can Psychoanalysis Unravel the Enigma of Psychosis? Now I will turn it over to Franco. Thank you.
Thank you to all. I would like to start by thanking the IPA for choosing the relationship between psychoanalysis and psychosis as a theme for this webinar and for appointing me as one of the speakers. Today's topic is psychosis. Does psychoanalysis have a chance? My idea is that psychoanalysis has many possibilities of understanding and treating psychosis as long as it broadens its vision. In other words, psychosis may show the limitations of psychoanalysis, but can also promote its further development. Unlike other disorders, psychotic illness takes a progressive course and can devastate the entire personality. Usually, analysts shy away from the idea of taking a psychotic patient to therapy, but it is not always possible to avoid having one. Sometimes it happens, as did to me, to take a patient into therapy thinking that he is only neurotic or depressed, and in the course of therapy, I have seen him develop a frankly psychotic episode. In general, analysts, young or older, are not trained to treat psychotic patients. Psychosis is not taught in institutes, and there is no constant debate in the literature on this topic that can stimulate curiosity and interest. It almost seems as psychosis represents for psychoanalysts an unknown and unknowable territory, a hic sunt leones, here are lions, a term with which the Roman named entire regions of Africa. Yet many analysts, starting with Freud and continuing with Ferenczi, Abraham, and then Arietti, Searles, and from Reichmann, and among the Kleinian analysts, Siegel, Rosenfeld, and Bion, have left an enormous treasure of discovery and intuitions that risk not being transmitted to younger analysts. What seemed to have happened is that after an initial commitment for the treatment of psychosis, a progressive discouragement has taken over so that the clinical and theoretical work on psychosis has progressively disappeared without there being an open discussion on this point. One of the reasons why psychoanalysts encounters difficulties with psychotic patients is that it is difficult to understand psychotic functionings because we usually work with a neurotic patient who function, as Freud taught us, using the dynamic unconscious, that is, with processes such as repression, symbolization, conflict, Oedipal issues, dynamics that are not present in this kind of patients. In each of us, there is an observing ego that has a truth criterion and can distinguish the newly created fantastic creation from reality. In the cases of psychotic individuals, this observing ego is lacking, and exploratory doubt, which usually accompanies each psychic act, is absent. In psychotic functioning, a voice or an illumination unveils a new reality to the patient, who believes that this new perception bears the truth. In psychosis, the mind proceeds by sensorial functioning, by sensorial revelations, and not by intuitions, and prevents the patient's ability to think and dream. The dynamic unconscious is paralyzed and does not allow intuitive and symbolic functioning. Often, in the case of psychotic patient, symbolic interpretation during the therapy create impasse or psychotic transference, which leads the patient to abandon the treatment. In reality, it is not psychoanalysis itself that is ineffective or iatrogenic, but the technique useful for neurosis that turned out to be contraindicated for psychosis. For this reason, Rosenfeld stated that it would be necessary for psychoanalysts, even those who are experienced and well-trained, to learn from scratch how to work with psychotic patients. Another difficulty to face the therapy of psychosis is preparing a different setting. It is necessary the presence of psychiatrists who know how to use drugs without interfering with the analytical work, and it is important a relationship with the family that is present in moments of crisis. To try to clarify my orientation, I want to talk now about my experience and how I approached the psychoanalytic study of psychosis. As a psychiatrist, I worked for almost 20 years in a psychiatric hospital where I had many psychotic patients in my care. The origin and the reason behind the crisis remained a mystery to me. At 40 years of age, I left the hospital and became entirely dedicated to psychoanalysis, with a silent hope of understanding better the mysterious nature of psychosis. For many years, however, I did not dare take care of psychotic patients. Despite even 20 years of psychiatric experience, I did not know how to convert my psychiatric expertise within a psychoanalytic context. At that time, a young patient with a past psychotic episode came to me requesting analogy. He told me he had had an acute psychotic crisis that had driven him to attempt suicide. After 7 years of analysis at 4 sessions per week, this patient had improved to the extent that I felt motivated to write a paper on hallucination and psychotic superego in the International Journal of Psychoanalysis. I was deeply perplexed, however, when, during a summer break, this patient had a new hallucinatory and delusional crisis that obliged us to stop the analysis. Naturally, I was sorry about the negative outcome of this long analysis and began to reflect on my limits. I continued to read colleagues' contribution on psychosis and was very impressed by some observations that Arietti and Searles had made. Both claimed that over the course of therapy, it was necessary to examine and understand the dynamics of the first psychotic episode. I had, however, been unable to do this with my patient because each time I had tried to speak about it, I saw that just simply remembering the crisis aroused unbearable anxiety in him. I realized that because the initial crisis had not been worked through, the underlying psychotic nucleus had left an indelible trace. Many questions filled my mind, and I understood I could not continue to reflect based only on my limited clinical experience, and so I decided to form an analytical group with several Milanese colleagues who were treating psychotic patients. Reflecting on the cases presented, many cases, I began to intuit the psychotic world of psychotic patients, although complex and at times incomprehensible, presented itself with several constants. By reconstructing the history of some patients, I gradually realized that they had had a certain kind of childhood. They had been isolated children who had distanced themselves from the world of relations without showing any particular suffering. So I decided to organize a second group, this time made up of child psychoanalysts and psychotherapists who had severely ill children in their care. I was convinced that in order to understand the origin of psychosis, it was necessary to investigate the life of children who seemed destined to become psychotic in adulthood. While discussing child case material brought in the group, I began to reflect on the concept of psychic retreat introduced by John Steiner. I began to think that a child who is destined to become psychotic is confined to a psychic withdrawal, a world made of sensory fantasies that gratify him and detach him from real life. My adult patient retrospectively confirmed this. Their history helped me understand that in childhood they had partly lived in dissociated reality, in a sensory world that had colonized their mind and which in adulthood had become a grandiose or persecutory psychotic world. Conceptualization of psychic retreat explains the concreteness, sensory nature of thought, grandiosity, and the resulting persecution, a lack of symbolic function and insight into one's mental state, as well as no distinction between the inner and the outer world. They are all the symptoms of psychotic crisis. From this moment, I began to think that it was possible to have a view of the process from a genetic, clinical, and theoretical standpoint. Testimony to this clinical work can be found in my book, A Psychoanalytic Approach to Treating Psychosis, where I relate a long, complex, and successful therapy with a psychotic patient. It is important to know that the patient lives in a dissociated world that usually, unless he is openly psychotic, does not communicate to the therapist, who only become aware of the pre-existing delusions after the crisis has occurred. The dreams of psychotics, therefore, are sometimes important because they anticipate the delusional themes. In the therapy, it is necessary to create constant communication between the healthy part of the patient and the analyst in order to discover how the psychotic part acts invasively and help the patient to distinguish what is exciting, psychosis initially is, but unhealthy, and what in the mind is constructive and worthy of development. This is important. It's not only a question of symbolical interpreting, but rather of increasing awareness, because the patient is convinced that the psychotic part, which suggests omnipotence, is healthy, because it gives pleasure and strength. Living in a retreat, the psychotic patient has not developed a real identity, and his personality falls apart, usually in youth, when he had to detach himself from the family and enter into a relationship with the world of emotions and conflict. I want to conclude by saying that for psychoanalysts, the study of psychosis remains an open field, a psychic world still unknown, just as the hysterical pathologies was in Freud's time. There would still be much to say about the clinical work and the theory of analytic therapy of psychotic patients, and I hope I can answer possible case questions during the discussion. In summary, I want to say, and I'm at the end of my paper, I want to say that psychosis forces us to go beyond what we have learned so far about the psyche in psychoanalysis, to go beyond the dynamic unconscious. Beyond the Dynamic Unconscious is the title of a new book of mine that will be printed in English next January by Karnac. Thank you. Thank you.
Thank you. Thank you, Franco. Thank you. Thank you for that. And great. So we'll have now our second presentation by Alfredo Ortiz Fragola. Alfredo is an MD, a training and supervising analyst at the Buenos Aires Psychoanalytic Association. He is a member of the Psychoanalytic Education Committee, IPA, since 2017. He is a consulting professor of psychiatry in the University of Buenos Aires. He's an international fellow, the American Psychiatric Association. He has been chair of the Mental Health Department, Clinic Hospital, University of Buenos Aires, and is chair of the Master in Psychopathology and Mental Health Program, Instituto Universitario de Salud Mental, Buenos Aires Psychoanalytic Association. He is in private practice of psychoanalysis, psychotherapy, and consultation in Buenos Aires. His psychoanalytic research focuses on narcissism, borderline personalities, adolescence, and relations between psychoanalysis and psychiatry. His latest and his last book is entitled Narcissism and Psychopathology of Our Time. Thank you, Alfredo, for being here. Look forward to your paper. I'll turn it over to you now.
Thank you, Elizabeth. First, I would like to thank my colleagues from the IPA Webinar Committee for the invitation to discuss this challenging topic, raised in a provocative way. Is there a chance for psychoanalysis in psychosis? Reflecting on what psychoanalysts think and do with the psychotic patient, we find a spectrum that goes from a somewhat omnipotent optimism when describing the analytical process with these patients, up to the prudent and subtle placement of these cases in the hands of other colleagues. In my view, one of the reasons why the dilemma sometimes generates controversy is because we are using a term, psychosis, which is not univocal. It can include semantic shifts. Semantic shifts or changes and differences in the meaning of a term are common in human science and especially meaningful with the passage of time. So in our topic, more than a century since Schreber, different perspectives that attempted to illuminate this territory have been developed and make it advisable for us to ask ourselves, what are we talking about when we talk about psychosis? Because there is a wide gap between castration anxiety and disintegration or fragmentation anxiety and the fear of collapse. Freud juggled psychology with neurology and literature in order to unravel his enigmas. Today, it is difficult to venture in the theory and even more into the treatment of a psychosis without leaving a place for early object relationships, linked dynamics, family bonds, and even, as Green pointed out not long ago, the presence of the soma. When dealing with severely disturbed patients with psychic fragmentation, some authors speak of psychosis, others of psychotic functioning or mechanism. A little further on, many see a continuum that goes from psychosis to borderline structure and narcissistic states, where there may be occasional psychotic functioning and psychotic symptoms as well. Let's go to a good point of reference, the clinic. In today's psychoanalysis, in many places, it is not very frequent for a patient with this integrative psychosis to initially consult a psychoanalyst. However, somewhat attenuated versions with fluctuating manifestations like bizarre thoughts or behaviors, suicide attempts, self-harm or cutting, or temporary loss of contact with reality, just to name a few typical forms, are frequent. These mental states alternate with periods of boredom, existential emptiness, or the search for chemical or sensual excitations in agonizing attempt to recover the meaning of a life worth living. With these patients, the analytic frame is particularly affected in moments of crisis, such as, for example, the analyst receives a desperate phone call in the middle of the night from a patient who distressingly reports delusional experiences. The interesting thing about a case like this is that in such a situation, with an uncomfortable or frightened analyst, the patient may end up hospitalized, while the same patient may calm down considerably after a telephone conversation and recover some stability as soon as he notices two things. First, that the analyst answered the call without avoiding it, without feeling that it damaged the setting. And second, that the patient can feel the analyst is talking to him while maintaining serenity, without ceasing to worry about what is happening to him. Of course, we know that it is not enough to remain calm. The turbulent alternatives of the analytic bond must not be reduced to a pure evacuative state. Although these patients find an integrative framework when they can take advantage of the stability that the analyst presents to them, the steps forward in their mental functioning will be taken when in transference bond there is room for interpretation, or a historicization that will have a restorative effect on the deficits in the psychic structure. It's common for many difficult patients to experience ineffable moods beyond our typical neurotic configuration. Whether through overwhelming affective states or hidden behind the passage to action, what lurks is a collapse of subjectivity. In these patients and at these moments, the central fears do not arise from neurotic anxiety. What is unbearable is boredom, existential anguish, and what worries more than death is non-life, used to say Winnicott. Thinking about some cases of this type that I had to face, I want to tell you about the appearance of the humanoid. And don't worry, I'm not going to tell you a movie. In dreams, in fantasies, in the latent content of their self-representations, often appears something that, playing with words like an adolescent patient once did, we could call humanoid. These moments correspond to what we could consider states of fragmentation of the self, something that these patients usually experience a disturbing imbalance, being on the edge of a mental abyss, like a staging that frightens and mobilizes others who receive projective identification. What could have happened in this case, as in so many other difficult patients? The humanoid, we could say the psychotic part, frightens, generates anxiety, and in its sinister tone, violence is detected and glimpsed. And at these moments, the analyst has to assimilate its impact in order to be able to think and not to expel interpretations that may generate more confusion or guilt in someone who at that moment does not distinguish well between the internal and external world. Early development researchers and psychoanalysts have long noted how infants draw on versions of their internal states provided to them by their caregivers, such that when things are going well, what is provided to the child is a version of his or her own mental state, not that of the caregiver. It is not too difficult to relate this process to the contribution that a good psychotherapist provides combining the acuity of that reflective function with the containment of the patient's emotional state. Borrowing some idea from Winnicott and Kohut, Karnac has suggested that when inadequate mirroring forces the child to internalize representations of a parental state rather than a version of his own experience, what is generated is an alienated experience of state of the mind. And in certain psychotic patients that we decide to analyze, this would correspond to the subjective experience of harboring strange feelings or ideas, as if they were not one's own. This is very near from the delusional thinking. I remember that patient of Joyce McDougall, a psychotic child whose mother, that is the one who had to fulfill the reflexive function in the early development of her son, said, "The problem is that I never know if I am angry, hungry, anxious, or want to have sex. And that is when I start drinking." Of course, these failures of maternal mentalization are ubiquitous. We all can have them or produce them to some extent. We all can have an integrated aspects of the self to some slight degree. In these patients, frequently becomes imperative to use interpersonal bonds, actions, or substance as regulatory elements that allow them to disperse their emotions and replace damaged or missing internal objects. In other words, to vicariously compensate for structural failures. About our work, I believe that it is not advisable to have more than 2 or 3 patients of this type in analysis at a time if we want to do things well, to keep intact the ability to be in touch with them and to be in touch with our own personal life. We live in a society that promotes, through an excess of certain stimuli or a lack of sufficient human context, the activation of our own humanoid regressive aspects. Of course, recognizing them is part of the analytic training, or the formation, as we used to say in Latin America. I mean, consideration of the narcissistic aspect of personality in didactic training analysis facilitates the ability to capture, tolerate, and not misinterpret these same elements in our patients. One question: do these patients or these aspects of patients occur frequently today? Yes, if we know how to see them, if we don't avoid them or leave them in charge of other sectors of the mental health system. Finally, some brief comments about the analyst's attitude and how to deal with the severely disturbed patient. There is a lot of in-depth research work about frame, countertransference, and negative therapeutic relation. I would say that the analyst, especially of seriously ill patients, has to endure the feeling of being a little crazy from time to time. I mean, from time to time, not always crazy, of course, and a little crazy, but not completely. He has to tolerate the patient considering him insane, like Searles used to say, or out of place, or being the freak. Tolerate the patient projecting his insane part onto him. And at the same time, not insistently promote the location on the part of the patient of his own sanity in the therapist. In some stages of the treatment of very disturbed subject, if the analyst, enthusiastic by intellectually attractive task, runs around chasing and interpreting all the scattered aspects of the fragmented interior and the hostile world, it will be difficult for the patient to emerge from the chaos. In this case, the person who least tolerates chaos is precisely the analyst, and consequently, faced with the therapist's need to find meaning where there is nonsense, the patient cannot relax because his feeling of trust has been destroyed. These frequent patients of today are sometimes psychotic At other times, they seem to be close to a breaking point. And at its least, they may inspire fear and worry. But it is not the genius of analysts or psychiatrists that brings them back to sanity. What is effectively necessary is usually to stay close to the subjective experience of the patient, although sometimes the conceptual knowledge of the analyst, the idealized frame of reference, may restrict his spontaneity. The analyst may be waiting for his patient to confirm his own theories, narcissistically detected, just as a mother observes her son's gaze influencing him. And the vulnerable subject in critical moments tries to hold on as best as he can to the objects, ideas, or interpretations of reality that are within his reach, in order to preserve something of his precarious stability. And the analyst is often a point of reference, even when he could be wrong in his assessment. So, intensity of the bond or prolonged treatment do not necessarily imply progress in the analytic process or validity of the analyst's theories. One last topic. In both the treatment and supervision of psychotic cases, we frequently find intense fusional experiences, interactive communications that resemble what Bolas has called aesthetic moments. They are rapture experiences that shelter the self and the other in symmetry and solitude. They express that part of the self and the other in which the experience of communion with the other constituted the essence of life before there were words. They are part of what is known but not thought. They are sometimes intense or cumulative experiences that occur in the intersubjective space and lead to a memory that is more experiential than cognitive. As you can imagine, with psychotic patients, this is linked to the restorations of the precarious or collapsed transitional space. Maybe that perhaps only later will we realize the weight of those crucial moments on the analysis. For example, when we start to review the case or write about it. In other cases, much later, the patient's story shows us, to our surprise, the specific weight that something we said or something we did had. The reliving, the actualization of early needs allows us to glimpse the tenor of the original faults that hinder the constitution of the self as a unit. For, as in any transference, also here, the present shows us or suggests to us the events of the past. And in the ancient past, the child's surroundings and his own self were undistinguishable. To conclude, even with its institutional entanglements or theoretical diversity, psychoanalysis remains a privileged path even in patients with psychotic functioning. Therapists with psychoanalytic training definitely have a valuable chance to capture the internal world and its turbulence, to facilitate growth, eliminate or avoid obstacles, and allow the development of potential resources. Thanks.
Wonderful. Thank you. Thank you so much for that, both of those thoughtful and I think very important observations and papers. I have a few observations myself, but I'm also interested in knowing if either of you made an observation or have a comment or a question for the other. So I will give you my observation and you could address it, or you might ask your fellow presenter a different question or make an observation. Something I noticed about both papers, both of them go back to something I think very fundamental, which is one is a question about what is psychosis? Like, how does one define it? So you were talking, Alfredo, about the semantic shifts and the gaps between how one defines psychosis. And I wonder about that in terms of what, Franco, you were talking about, which is having an open discussion about this point, where after an initial commitment by psychoanalysis in treating psychotic patients, that has in a way fallen off or has fallen off. So I wonder about the kind of history and how history or these questions of definition might inform how today in contemporary practice this might be addressed. So that's one question you could think about and address, or there may be something else that you want to entertain given the papers of each other.
I can say something about the diagnosis of psychosis. In my work, I treated psychosis as a process. I describe the childhood of psychosis patient that I can reconstruct during the analysis. No? The analysis of psychotic patients is a very long analysis because the patient has inside the nucleus psychosis that always recur many times, no, during the analysis. And often we have analysis with many crises, also something with hospitalization, no? This is a structural, a process, a psychotic process. In other individuals, there are an episode. For example, the mother after the birth can have a puerperal psychosis. No? This is an episode. We have to distinguish between an episode and a process, a psychotic process. No? In my view, the psychotic process is very difficult and long to treat, and they began from the childhood. No? The other episode crises, they are not a process, they're an episode in traumatic experience, no? And so on. This is a very important distinction for me.
Yes, thank you. Thank you, Franco.
Of course, I think we are speaking about the same things. The same patients are the kind of patients we have seen along our career. We can formulate in different ways, but we are speaking about the same. I think that when you, therefore I underline the issue of the terms. When we say psychosis, when we may be speaking about the functioning, or may the origin of the term, when Freud began to speak about neurosis and psychosis, he was speaking about a classification that still today functions, but it doesn't mean that we are all in synchrony with that. The classifications in it is like an order to orientate in the obscurity, in the darkness. And in the extremes, it's clear there are psychosis. Some people say processual psychosis. They have a genetic influence, strong genetic influence, and it goes through a disintegration of the personality. That's where the patient begin as a person who has a future, but he really has not a future. And I think this is very different. Franco said something similar to this, to suffer from a psychotic episode along the life. And for example, a puerperal psychosis or psychosis after a traumatic episode or other kind of episodes. But there is another kind of people who have an organization of their personality precarious, and they live a life that may be lived, but with a lot of suffering, and they can work and live well, but in certain episodes, they disintegrate. These patients are more accessible to psychoanalytic treatment. The others are much less. It doesn't mean that you have never the possibility to do that. But anyway, in both cases, I am almost sure that it is necessary not only to look at the patient without looking at his family, his early object relations, as we have said it before. And that's where psychoanalysis have more to do, more of its real potential to offer to the patient.
Thank you for that. I have another question. In reading both of your papers and in thinking about this, and in my own experiences, I'm wondering what you think, because it seems very hopeful to me. Both of your papers are very hopeful, and that psychoanalysis is one route or an important route to treating patients with psychosis. What do you think is the best way to begin the discussion, I suppose, like this, but also how to, I think in some ways give confidence or to psychoanalysts who might be wanting or willing or feeling that psychoanalysis is a viable and important way to treat patients with psychosis. What do you think in terms of the beginning or the first thing? I mean, I think about psychoanalytic institutes. Maybe that's because I'm a teacher myself, but I think about the role that institutes might play. But what do you think, and is this even a question that you're interested in, or is this something you think about yourself?
You know, Elizabeth, while I was hearing Franco and you, you told us to begin this webinar talking between us. I don't know why, but I wrote in a paper something that I hadn't thought about before when I was writing this paper or this presentation. That is the possibility to include more than what it is up to now of the psychotic treatment, psychotic patients, psychotic mechanisms in the training of the institutes of psychoanalysis, at least as a postgraduate, because we all know that psychoanalysis began and was made strong with the neurotics configurations, although it's much more than this, and as we both said, there are psychoanalysts who work and elaborate the theories about what's happening with a psychotic patient, and Franco is one of them. But what I mean is that in the training of young analysts, or not so young, there is not so much about this. It depends more of their own interest and of another issue, that is the trajectory. How was the work of that professional along his career? Franco has told us he worked in a psychiatric hospital during, you said 20 years, I think, Franco. And
Yeah.
then he went to the Psychoanalysis Association, and that it was a sequential, first one and then the other. I made in a different way. Of course, I don't say one is better than the other. There are two roads. I was in a general hospital, in a psychiatric service, in parallel with where I did my psychoanalytic formation training. This introduces some differences. Well, I let Franco, then I go on if you want. I don't know.
Okay.
Yes, I think that it is necessary that psychosis could be taught in institute, but there is a big problem because I learned to work with neurotic patient, interpreting transference, interpreting dreams, interpreting communication, be attentive on my counter-transfer. This kind of psychosis is not good for psychotic patient, this kind of attitude, because the mind of psychotic patient is not an intuitive psyche, is a sensorial mind. I ask myself why this patient is prone to have hallucination and delusion, no? The hallucination and the delusion are constructed with sensorial, with the mind that functions sensorially, like the patient psychotic told us, I saw this one, I see this one, I see my mother, I see my friend, I see my enemy, I hear voices, no? So the mind of psychosis is sensorial. It's not infantile, because also the child are sensorial, no? They play with the sense. And also we have to understand for the first time how psychotic patients use their mind, no? And if you interpret a dream of the patient understand that you are showing another reality, because we give to the patient a symbolic interpretation of the dream. In the mind of psychosis, you are talking that there is another reality. And often this patient began to think that you can make him fool, crazy, because you are speaking about another reality. So no interpretation symbolic. You have to try to have a collaboration, a communication with the same part of personality. And the same part of personality has to understand how the psychotic part function works. And we have to grow, to construct and grow the part of personality, the same healthy part of personality, in order that the healthy part of in this I underlined that Arietti and Searle told us that we have to come back to psychotic, the first, in order to understand with the patient how he constructed his psychosis, no? Using the sensorial mind, not the thinking mind. So it is difficult. Allora, in institute, we learn how to understand a normal, a neurotic patient. And We learn this in many years, not immediately. I think that Alfredo is right, thinking that it needs to approach with a postgraduate teaching. No?
Well, I agree in most of what Franco says. The only difference it would be about these issues we are talking about in this moment is that I see what Franco has described it about the hallucinatory process, and also the delirium, delusion process, as stated in an extreme of the more clearly psychotic patients. But I see I prefer to see like a continuum that goes from the neurotic, not neurosis and psychosis, but from the neurotic towards the psychosis, both of them in an extreme. In the stream of the psychosis, I see word by word I think I agree what Franco says. I think that there are another intermediate states that I am like those who say that there is a continuum from the psychosis to the borderline states to the narcissistic states. And in those borderline, what happens? They can function in some moments as a perfectly individual with all his mental functions and his life working and loving and tumultuous in a tumultuous way and with a lot of conflicts, but working and doing whatever, seeing the reality with a clear distinction between internal and external world. But in certain moments, certain moments of their life, of their development, maybe in the adolescence, maybe after a crisis in her loving partner, they may present psychotic symptoms. And then you have the psychotic. After that, you have the neurotic. And you have to have, you need to have as analysis a gymnastic capacity to jump from another position to the other, but maintaining in each stage the capacity or the ability or the intention to go into the subjective experience of the patient. Very distant from our usual experience if there is a psychotic moment, more near if it's an intermediate moment. And in the patients, of course, in the patients with the strong hallucinations and in the extreme of this line, there is needed a joint work with psychopharmacology that helps us to rebuild this subject.
Thank you. Thank you both. I'm going to turn to some questions from the audience. So the first one is, if a psychotic world develops as a means of avoiding a painful reality, why does it often lead to an even more painful and darker experience?
I don't know if I understood well the question, but I think that it's important to think when we treat psychosis, that psychosis lives in a dissociated reality. I'm not agree with Alfredo. There is a possibility to pass from neurosis to psychosis. There are two worlds together in the individual. the neurotic part, psychotic part. The psychotic part begins in the childhood, when the patient, the child, is not together the companion, the partners, no, is isolated, and his mind is constructing a psychotic part of personality, identified with the great, very big person, very omnipotent world. This kind of personality remain in, come dire, equilibrium with the neurotic part. But when the patient is growing and is detached from his family, the part of personality psychotic invade, dominate the neurotic part. And this is the first psychotic crisis. We have to remember that psychosis in Kraepelin, the first psychiatric known psychosis, dementia precox. No? Dementia precox. It seems that all the part of personality went crazy. Dementia. No? Allora, in this case, I can answer to the question. If for the first moment, the psychotic part is positive. You are a great home, you are Freud, you are Einstein, you know everything, and destroy the sane part. When this process is at the end, there is anxiety, because the sane part is dead, as a patient is very afraid not to come back. Bion said that the psychosis destroy the same elements that can come back to the sanity. And it is a very tragedy. With the psychopharmacy, with the drugs, we can work easily, because with the help of psychiatrists, this terrible anguish can be reduced, no, contained.
Alfredo, do you want to
Yes.
address the question? Or?
If you can repeat the question, and I
Yes.
mix it with the answer of Franco, with which I have something to say. But if you can repeat the question, please.
That'd be great. Yes. If a psychotic world develops as a means of avoiding a painful reality, why does it often lead to an even more painful and darker experience?
We could answer. It's not. Still, it's not so clear for me the question. A psychosis means something that doesn't go well. It's not an exit. It's not an exit. It's a failure. I insist in what I think. I prefer to think about psychosis in an extreme. That's dementia precoce from Kraepelin. That means the destroying of the personality. That means a genetic influence. You can easily look at it in the family of those kind of patients. And probably the possibilities, as I see, the possibilities of psychoanalysis in those patients is limited, because the organization of the personality is in isles. It's not an organic function. And then it doesn't mean that an psychoanalytic informed therapist will help a lot to that patient in this new, when he's trying to reconnect with the world. A failure in much times, sometimes it may go, but with a deficit, a certain kind of deficit. Or there are a lot of patients who present, for example, when Franco mentioned those people with a depression or some kind of neurotic anxieties that begins a classic psychoanalytic treatment, and during that treatment appears a psychotic crisis. I think clearly that this is a different patient that one who describes Bloiler and Kreppelin and who go in a way to the destroying of their personality. That's why I prefer the concept of the borderline personalities that imply there are clearly psychotic moments, but the personality has at least a precarious organization. And in a precarious organization, there are moments where they can clearly distinguish between internal and external world. And another word about omnipotence, feeling to be Freud or to be Einstein or to be the president. I know many people who in their unconscious, they feel to be the best. And it's a problem in their quotidian life. What I'm trying to say, that omnipotence is also in us. And also us, although we may believe that we are a bit more normal, we have those kind of aspects in our personality. But we can separate a little more clearly from internal and external world.
Okay, thank you. Thank you both. I have a question here. This one says, I wonder if Dr. Masi has investigated work with psychotic patients at the Bergozzi, where Carl Jung and others worked intensively with this population. Is this center still a world reference in the matter?
I understood. I did not understand. What is the question?
They're asking if you have investigated work with psychotic patients at the Bergozzi, Burgholtzi, where Carl Jung and others worked intensively with this population, and asking, is this center still a world reference in this matter? So asking if you're, asking if you're familiar with and have worked with patients at this.
I don't, because there are confusion in transmission. They have not a good line in this moment.
Ah, okay. Well, why don't
I don't know if the question was referred to a specific center for the treatment of psychotic patients, but I don't know to which center, where and which center, because there are some people who has worked with patients, like Franco says, but I don't know. He mentioned Jung.
Yes.
I don't know.
Burgholtzi?
It's a Swiss clinic where Jung worked.
Yes, Jung worked because Jung was the first to speak with the psychosis patient, no?
Yes.
He was very, very clear. He was very interested in speaking about with the patient, and also to try was the complex. He tried to find the complex of psychosis patient. No, he was he have a priority, was advanced before also the other people. Abraham worked with the young. He criticized a lot Abraham.
Yeah.
But he was, and also the vision of Jung was a psychotic view. There is a very interesting confrontation between Freud. Freud has a neurotic nucleus, but Bion had a psychotic nucleus. He saw the young perception of Jung was sensorial, was not hallucination, but a mind of. It also he developed a system of unconscious, world unconscious. He worked with the psychosis, but at the same time, it's not. In this time, there is not a theory about psychosis. Also, there are no theories about neurotic. So it's not possible to develop a therapy without a theory, no?
Yeah, yeah.
I think we are not discovering America. There are a lot of psychoanalytic research in psychosis, and there are some people who have developed a lot of theories and information and experience. We have today mentioned some of them, like Bion, Harold Searles, Herbert Rosenfeld, an Argentine, David Rosenfeld also, with the family of the schizophrenia patients, Garcia Badaraco, all psychoanalysts. And they all had worked from their own perspective, and we can join all this information to understand more clear the patients with this kind of pathology, and to stand in front of them and to think, are they all the same? That's one question. Everybody is sure that he will never present symptoms like that. Just think a small issue. If somebody consumes certain drugs, he has a psychotic experience. That's what happened, for example, with psilocybina and a lot of other psychotic mimetics drugs. If the patient, the subject has a predisposition, he can develop psychosis. There are a lot of young people who develop psychosis after smoking marijuana. There are a lot, hundreds and millions of people who smoke marijuana and don't develop a psychotic episode. I mean, there is an equilibrium in the maintainment of the difference between internal and external world, on the limits, I mean, not the difference. And it has to be with all of we are talking about.
I have a question that may be somewhat related to that. The question is the manic state, and I have quite a few other questions, but is the manic state the little sibling of the psychotic state? The manic state, is it, quote, the little sibling of the psychotic state?
Little sibling.
Yes, like a kind of mini, or...
For me, no, they are different problems. Psychotic state of manic depressive illness is they are siblings, but not, they are very different. because in psychotic state there is a psychic retreat, no, from the childhood, an omnipotent that govern, that try to invade this part. There are also psychotic state with manic symptom, because when I am God, no, because I am God, the voice give me the suggestion that I am God. They are in manic situation, but there is a symptom. There is some manic state with psychotic crisis. They are dynamically, they are very different, because the patient manic after some time become depressed, no? And the psychotic state is continues to grow in hallucination, in delusion, and at the end, the personality is completely destroyed. The manic patient continue to have personality, no? There are very differences, you know, for me.
Yes, I agree. There are differences. There are similarities also. Nowadays, we all speak of bipolar disorders more than manic depressive, but it is practically the same. But the difference when we speak of bipolar disorders is that, again, is that there is a spectrum. Not only the manic depressive who goes from one episode to another, but to other slight, more soft episodes that create confusion, sometimes in the clinic, in about the differentiation with the psychotic schizophrenia-like disorders. That's why I spoke about psychosis. When we speak about psychosis, a psychosis may be an schizophrenic, a borderline who has a psychotic episode, but maybe a manic episode is called a psychotic all over the world. The individual is in a psychotic state. It's a psychosis for the law, for everybody, but they are quite different. So the semantic shifts, therefore, create a problem, but make us to think.
I'm going to ask, we're getting close, but I have a few other questions. I'm going to try to get this one in. A question for both of you. What is the main difference in the countertransference with a psychotic patient? The main difference in countertransference with a psychotic patient?
I suppose it is asking about the difference with the neurotic patient. The difference between what? Between psychotic countertransference, psychotic and neurotic, I suppose.
I think so. I think that's the question. Yes.
For me,
all the clinical picture that spreads in the transference spreads and gets to the analyst in the countertransference. And that means that intense feelings, intense hate, intense love, and mainly the indiscrimination between internal and external world spreads in the countertransference. So it will be more easy to detect, but much more difficult to control it and to think about it. But anyway, it's an essential tool to understand and to manage what's happening with that kind of patient. Anyway, it's also a tool with the neurotic patients, but the intensity of everything is higher, like in the psychotic triplets.
No,
Yeah.
my countertransfer changed during the years, also during the decades of treating and supervising psychotic patients. Because the first time I was very perplexed, also emotionally traumatized for the difficulties in which we have to work with the patient, because the patient also, when you have a good transitorial benefit, often the patient have another crisis. No, there is a beautiful paper of Anna Siegel, who treated a patient for years. The therapy was very good, but after 20 years, the same patient came back with another. No, for me, the psychosis is like a cancer. No, the cancer is no, a diffusion on the body. So my contact transfer is to have patience, a continuing patient to wait to wait for years, because the patient is not able to understand, to introject, and so it's a very heavy work. No, my contact transfers now is capable, also in supervising, to stand the frustration, this kind of work. But after years, when you succeed in obtain such a good exit, this is a very healthy position, very good situation. But you have to work for years to understand everywhere. For me, when my patient has another psychotic delusional hallucination, for me, I ask myself, what I've not understood. I did understand all. I have to understand continuously.
Yes. Thank you.
Can I add something?
Yes, this
Elizabeth?
can be, we just have a few minutes left. So if you want to
Yes.
say just a few things, Alfredo, and then
Yes,
Franco.
just about this. That's the reason why I told when I spoke about how to deal with the psychotic patient. We need to be able to stay a little crazy from time to time, and not completely crazy, but craziness gets up to us, and we must contain not to reaction with an immediate interpretation.
Thank you. Franco, do you have anything, both of you, we only have just a few minutes. Is there anything else you want to add before we close the session?
No, I think that IPA had to continue to organize, to organize the research on psychosis. It would be a good thing if there will be an organized method with a group of psychoanalysts allowing comparison between homogeneous clinical cases. We have to confront, in international team, and exploring childhood symptomatology and development of many patients, because if analysis would have some comfort, some recognition, you have to develop this kind of field. No, it's difficult. Like I said, like I told, like Freud did with hysterical. Hysterical was consider it a degeneration, a cerebral idiot, not a psychic suffering. And we have to join our effort in order to know more and more on psychotic functioning. We can do that.
I think that I agree. This has been, oh, Alfredo,
Yes,
two sentences.
very brief. It's just a final comment. I think that the accumulated experience show us that the various theoretical perspectives on psychosis and the techniques that are derived for them are useful for some patients, but not for all. We could say that they are just as toolboxes that we can select, and they help us to work with different patients. And of course, also, each analyst is better at handling the style and framework that suits him best.
Great. Thank you. Thank you for that. I want to thank both of you for the fantastic papers, for the wonderful discussion. I wish we had another hour. There were so many great questions. I had more questions. I hope that both of you, and I hope that, like you said, that the discussion continues, because I think it's an important topic and a relevant one, especially today. So thank you both for your time, and I'm happy I got to be the moderator. I'll say just a few words about upcoming events. There will be a webinar on October 25th. Everyone should look at the www.ipa.world. Go to the IPA website for more information about that webinar. And I hope I will see both of you, Franco and Alfredo, again. And thank you. Thank you for your participation in this really fantastic and wonderful webinar. Appreciate it. Thank you.
Thank you to you.
Okay, take care. Bye now.